A heart that contracts randomly doesn't pump blood. The genius of the heart is its conduction system, a precisely timed electrical network that turns a chaotic muscle into a coordinated pump. The signal starts in the sinoatrial node, a crescent-shaped cluster of pacemaker cells in the right atrium near the entry of the superior vena cava. The SA node fires 60 to 100 times per minute at rest. The signal spreads radially through both atria, cell to cell, via gap junctions, depolarizing the atrial muscle and causing atrial contraction. This depolarization is what creates the P wave on the EKG. The signal then reaches the atrioventricular node, sitting at the floor of the right atrium near the coronary sinus. The AV node is slow on purpose. Conduction through the AV node takes about 100 milliseconds. This is the AV nodal delay. This pause shows up on the EKG as the PR interval. Why slow down? Because the ventricles need time to fill before they contract. The atrial kick, the final bit of ventricular filling from atrial contraction, contributes about 20% of end diastolic volume in a healthy heart. Without the delay, atria and ventricles would contract simultaneously and filling would fail. After the AV node, the signal accelerates dramatically. It enters the bundle of His, splits into right and left bundle branches running down the interventricular septum, and then fans out into the Purkinje fibers, which depolarize the ventricular myocardium from the apex upward. Purkinje conduction velocity is around 2 to 4 meters per second, the fastest in the heart, which lets both ventricles depolarize almost simultaneously. That rapid, synchronized depolarization is what creates the sharp, chip, narrow QRS complex on a normal EKG. After ventricular depolarization, the ventricles contract. On the EKG, the ST segment corresponds to phase 2 of the ventricular action potential, the plateau when all ventricular cells are depolarized at the same voltage, so there's no net electrical signal to record. Then the T wave emerges, representing ventricular repolarization. Putting the EKG back together, P wave, atrial depolarization, PR interval, AV nodal delay, normally 120 to 200 milliseconds. QRS complex, ventricular depolarization, normally less than 120 milliseconds wide. ST segment, plateau should be flat. T wave, ventricular repolarization, 1 heartbeat, 1 pQRST. The SA node isn't the only cell that can pace the heart, it's just the fastest. If the SA node fails, the AV junction takes over at 40 to 60 beats per minute. If the AV junction fails, the ventricular Purkinje system pacemakes at 20 to 40 beats per minute. This is the hierarchy of backup pacemakers. The mechanism that enforces this hierarchy is called overdrive suppression. A faster-firing pacemaker repeatedly depolarizes the slower cells, which drives intracellular sodium up, activates the sodium-potassium ATPase, and hyperpolarizes the slower pacemaker's membranes. The slower pacemakers don't just lose the race, they're actively quieted. That's why, clinically, when a faster pacemaker suddenly stops, you see a characteristic pause before the slower escape rhythm emerges. The escape pacemaker needs a moment to recover from the suppression. Clinical anchor. Third-degree atrioventricular block, also called complete heart block, happens when the AV node, or His-Purkinje system, fails completely. The atria and ventricles beat independently. On EKG, you see P waves marching at their own rate and QRS complexes at a slower escape rhythm. The patient is usually symptomatic and needs a pacemaker. A wide QRS, anything over 120 milliseconds, is a warning sign. It means the impulse is traveling through ventricular muscle rather than the specialized Purkinje system. That's what you see in bundle branch blocks, premature ventricular contractions, and ventricular tachycardia. The signal has detoured through slow-conducting muscle. Wide and fast usually means ventricular origin until proven otherwise. One more piece. The autonomic nervous system tunes the system. Parasympathetic input through the vagus nerve slows the SA node and AV node. That's why vagal maneuvers like carotid massage or the Valsalva can break certain supraventricular tachycardias. Sympathetic input speeds both nodes and increases ventricular contractility. Every clinical change in heart rate and conduction passes through this electrical highway.